Universidad Técnica de Machala Facultad de Ciencias Químicas y de la Salud Carrera de Ciencias Médicas. Pathologies of the nervous system. Neurodegenerative disease. The term neurodegenerative disease is an umbrella term for disorders in which there is a progressive loss of the structure or functions of the neurons. Alzheimer's disease. Alzheimer's disease is a group of disorders involving the parts of the brain that control thought, memory, and language. It is the leading cause of dementia and is marked by progressive deterioration that affects both the memory and reasoning capabilities of an individual. Anatomy. Healthy neurons have an internal support structure partly made up of structures called microtubules. These microtubules act like tracks, guiding nutrients and molecules from the body of the cell down to the ends of the axon and back. A special kind of protein, tau, binds to the microtubules and stabilizes them. In AD, tau is changed chemically. It begins to pair with other threads of tau, which become tangled together. When this happens, the microtubules disintegrate, collapsing the neuron's transport system. The formation of these neurofibrillary tangles, NFTs, may result first in malfunctions in communication between neurons and later in the death of the cells. In addition to NFTs, the anatomic pathology of AD includes senile plaques, SPs, also known as beta-amyloid plaques, at the microscopic level, and cerebrocortical atrophy at the macroscopic level. The hippocampus and medial temporal lobe are the initial sites of tangle deposition and atrophy. This can be seen on brain magnetic resonance imaging early in AD and helps support a clinical diagnosis. Pathophysiology. The two pathologic hallmarks of Alzheimer's disease are extracellular beta-amyloid deposits, in senile plaques, intracellular neurofibrillary tangles, paired helical filaments. The beta-amyloid deposition and neurofibrillary tangles lead to loss of synapses and neurons, which results in gross atrophy of the affected areas of the brain, typically starting at the mesial temporal lobe. The mechanism by which beta-amyloid peptide and neurofibrillary tangles cause such damage is incompletely understood. There are several theories. The amyloid hypothesis posits that progressive accumulation of beta-amyloid in the brain triggers a complex cascade of events ending in neuronal cell death, loss of neuronal synapses, and progressive neurotransmitter deficits. All of these risk factors and etiology. The cause of AD is unknown. Several investigators now believe that converging environmental and genetic risk factors trigger a pathophysiologic cascade that, over decades, leads to Alzheimer's pathology and dementia. The following risk factors for Alzheimer-type dementia have been identified: advancing age, family history, APOE4 genotype, obesity, insulin resistance, vascular factors, dyslipidemia, hypertension, inflammatory markers, Down syndrome, traumatic brain injury. Symptoms of Alzheimer's disease. The most common early symptom of Alzheimer's is difficulty remembering newly learned information because Alzheimer's changes typically begin in the part of the brain that affects learning. As Alzheimer's advances through the brain, it leads to increasingly severe symptoms, including disorientation, mood and behavior changes, deepening confusion about events, time and place, unfounded suspicions about family, friends and professional caregivers, more serious memory loss and behavior changes, and difficulty speaking, swallowing and walking. Diagnosis of Alzheimer's disease.
To diagnose Alzheimer's, comprehensive medical evaluations are necessary, including detailed medical history, assessment of mental state,
and mood, physical and neurological exam. Tests such as blood tests and brain imaging studies, to rule out other causes of dementia-like symptoms. Treatment. To date, only symptomatic therapies for Alzheimer's disease, AD, are available and thus do not act on the evolution of the disease. All drugs approved by the U.S. Food and Drug Administration, FDA, for the treatment of AD modulate neurotransmitters, either acetylcholine or glutamate. The standard medical treatment for AD includes cholinesterase inhibitors, CHEs, and a partial N-methyl D-aspartate, an MDA, antagonist. Secondary symptoms of AD, EG, depression, agitation, aggression, hallucinations, delusions, sleep disorders, can be problematic. Behavioral symptoms in particular are common and can exacerbate cognitive and functional impairment. The following classes of psychotropic medications have been used to treat these secondary symptoms: antidepressants, anxiolytics, antiparkinsonian agents, beta blockers, antiepileptic drugs, for their effects on behavior. Prevention of Alzheimer's disease. This suggests that healthy lifestyles can reduce the risk of AD. Physical activity, exercise, and cardiorespiratory fitness may be protective. Stroke. A stroke, or CVA, is properly known as a cerebrovascular accident. This condition is damage to the brain that occurs when the blood flow to the brain is disrupted because a blood vessel is either blocked or has ruptured. Strokes are currently the third leading cause of death and the primary cause of long-term disability. The location of the disruption determines the symptoms that will be present. An ischemic stroke, which is the most common type of stroke in older people. This type of stroke is caused by a blockage in an artery that supplies blood to the brain. The blockage reduces the blood flow and oxygen to the brain, leading to damage or death of brain cells. If circulation isn't restored quickly, brain damage can be permanent. Approximately 87% of all strokes are ischemic stroke. There are two main ways that an ischemic stroke happens. One mechanism is endothelial cell dysfunction, which is when something irritates or inflames the slippery inner lining of the artery. The tunica intima. One classic irritant is the toxins found in tobacco, which float around in the blood, damaging the endothelium. The damage becomes a site for atherosclerosis, which is where a plaque forms. This is when a buildup of fat, cholesterol, proteins, calcium, and immune cells forms and starts to obstruct arterial blood flow. This plaque has two parts to it: the soft, cheesy textured interior and the hard outer shell, which is called the fibrous cap. Another mechanism for ischemic stroke formation is an embolism. An embolic stroke typically happens when a blood clot breaks off from one location, travels through the blood, and gets lodged in an artery downstream, typically an artery, arteriole, or capillary with a smaller diameter. These blood clots typically emerge from atherosclerosis, but they can also form in the heart. One specific type of ischemic stroke is called a lacunar stroke, and they typically involve the deep branches of the middle cerebral artery that feed the basal ganglia. Called that since after a lacunar stroke the damaged brain tissue develops fluid-filled pockets called cysts that look like little lakes under a microscope. This can happen as a result of hypertension or diabetes. Risk factors. Circulatory conditions are the main risk factor for ischemic stroke. That's because they increase your risk for clots or fatty deposits. These conditions include high blood pressure, high cholesterol, atherosclerosis, prior heart attack, clotting disorders, congenital heart defects, atrial fibrillation, sickle cell anemia, others, diabetes, smoking, being overweight, use of certain drugs and alcohol. Symptoms. Symptoms of ischemic ACV or stroke vary depending on the type and part of the brain that is affected. Stroke symptoms usually occur suddenly, within seconds or minutes. For example, an anterior or middle cerebral artery stroke can cause numbness and sudden muscle weakness. If a stroke affects the Broca's area, which is usually in the left frontal lobe, or Wernicke's area, which is usually in the left temporal lobe, then it can cause slurred speech or difficulty understanding speech, respectively. If there's a posterior cerebral artery stroke, then it can affect vision. An acronym to remember some common stroke symptoms is FAST, facial drooping, arm weakness, speech difficulties, and time. Time is obviously not a symptom but just a reminder to get help as quickly as possible to minimize cell injury and maximize the chance of a full recovery. If you notice that someone has any of these symptoms, you should call for emergency help immediately as they could be having an ischemic stroke. Diagnosis. A doctor can usually use a physical exam and family history to diagnose ischemic stroke. Based on your symptoms, they can also get an idea of where the blockage is located. A cranial CT scan can also help distinguish ischemic stroke from other issues that cause brain tissue death, such as a hemorrhage or a brain tumor. An MRI is the best way to determine when the ischemic stroke started. The first goal of treatment in an emergency is to restore breathing, heart rate, and blood pressure to normal. If necessary, your doctor will try to reduce the pressure in the brain with medicine. So thrombolytic enzymes, like tissue plasminogen activator or TPA, are used to activate the body's natural clot-busting mechanisms, but TPA does have a time limit of when it can be used. Aspirin is also used to prevent platelets from forming additional clots. If TPA is unsuccessful, surgical procedures can be used that push a wire through the artery and physically remove the clot. In mechanical embolus removal in cerebral ischemia, called MRSI for short, the wire grabs onto the clot and draws it out of the artery. In suction removal, the wire is used to physically break down the clot and clot fragments are removed with suction. After a stroke has occurred, there is an elevated risk of having additional strokes, so it's important to minimize risk factors. The main one being quitting smoking. But others include having a healthy blood pressure, normal LDL cholesterol levels, and controlling other diseases like diabetes. Guillain-Barré syndrome, GBS, consists of an autoimmune polyneuropathy, with heterogeneous clinical variants. In most cases it presents as a monophasic paralysis preceded by an infection. The demyelinating form is the most common. It is a disease that presents with acute paralysis secondary to inflammation of the peripheral nerves and nerve roots, clinically manifested as paresthesia, numbness and progressive weakness of the extremities until walking is impossible. It can affect the muscles of the face, swallowing and ventilation. The incidence of Guillain-Barré syndrome is 0.89 to 1.89 cases per 100,000 inhabitants per year, with a male predominance of 1.5 to 1.781. The incidence increases with age, varying from 0.62 cases per 100,000 inhabitants/year in the age range of 0 to 9 years, to 2.66 cases per 100,000 inhabitants/year in the age range of 80 to 89 years. It may appear over the course of several hours, several days, or it may take up to 3 or 4 weeks. It is associated with infectious processes. Most people reach the stage of greatest weakness within the first 2 weeks of the onset of symptoms, and by the etiology, the Guillain-Barré syndrome represents the prototype of immune-mediated peripheral neuropathy, today recognized as a group of conditions with diverse pathogenesis and pathology. GBS has been more frequently associated with infection. It often occurs days to weeks after a respiratory or gastrointestinal infection. Many microbial agents have been implicated, including Campylobacter, cytomegalovirus, Epstein-Barr, Haemophilus influenzae, Mycoplasma pneumoniae. Pathological findings are limited to the peripheral nervous system, with multifocal inflammatory demyelination being the pathological framework of GBS. Guillain-Barré syndrome is believed to be caused by an autoimmune response to foreign antigens. The site of damage is gangliosides, which are present in large numbers in nervous tissue, especially in the ganglia of Ranvi. The end result of these autoimmune attacks is the loss of myelin and, consequently, the blockage of nerve conduction. Despite this, axonal function remains intact and recovery can be as rapid as with remyelination. 2/3 of GBS patients develop neurological symptoms 2 to 4 weeks after a respiratory or gastrointestinal infection. More than 90% of patients reach disease nadir in 2 to 4 weeks. However, recovery of function occurs slowly over weeks or months within the initial symptoms we have: instability in gait, neuropathic pain, leg weakness, bulbar weakness, dysphagia, loss of proprioception, areflexia. We also find the following clinical picture: autonomic dysfunction, cranial nerve involvement, weakness in the upper extremities, affection of the muscles of respiration within the classic triad found in Guillain-Barré syndrome. We have upward weakness, slight paresthesias of the hands and feet. Reflex. Classic Guillain-Barré syndrome can be associated with sensitive symptoms, such as pain. It can be associated with autonomic dysfunction. Acute motor axonal neuropathy, NAMA, similar presentation but shows axonal involvement. Acute sensory motor axonal neuropathy, NESMA. The axonal component involves efferent fibers and the sensory involvement is more prominent than in the classical form. Miller-Fisher syndrome, MFS, considered the most common variant of Guillain-Barré syndrome, is characterized by the acute presentation of apollinaropathy with areflexia, ataxia and ophthalmoplegia. It can be difficult to diagnose Guillain-Barré syndrome in its early stages, since several disorders have similar symptoms, so doctors must examine and question patients and their families before making the diagnosis. Treatment: there is no specific cure, and management consists of treatments that reduce the severity of symptoms and speed recovery in most patients. Plasmapheresis and high-dose immunoglobulin treatment are generally the therapy of choice. Both are equally effective, but immunoglobulin is easier to administer. Thank you very much for your attention.